Hello, nursing champions. Welcome back. Today's video focuses on pharmacology of musculoskeletal, where we'll work through 15 high-yield questions on bisphosphonates, disease-modifying anti-rheumatic drugs, muscle relaxants, non-steroidal anti-inflammatory agents, biologics, and more. Each one explained step-by-step to strengthen your clinical judgment and NCLEX readiness. You'll learn how these medications act, what adverse effects to watch for, and how to administer them safely. Knowledge that often appears on the exam. We release fresh, exam-focused nursing content every single day, so make these concise, practice-oriented sessions part of your routine. Follow us and tune in daily for the must-know topics and questions that will help you ace your NCLEX with confidence. Before we dive into today's question, let me ask, are you completely prepared for the NCLEX? If there's even a bit of hesitation, our complete NCLEX review online course has your back. You'll get access to 100 hours of animated content, 500 hours of in-depth lectures, 5,000 high-yield questions, 500 NGN-style case studies, and 15 mock exams designed to feel like the real thing. You'll also receive a comprehensive NCLEX ebook, all valid for 1 full year. Right now, you can grab it at 70% off for a limited time. Thousands of students are already on the path to success. And you can be too. Click the link in the description and get started. Let's dive right into it with question number 1. A 68-year-old client with visible toffee and a fasting serum uric acid, concentration of 9.8 milligrams per deciliter, is about to begin long-term therapy aimed at lowering total body urate and preventing further gouty flares. Which medication should the nurse anticipate the prescriber will order to achieve this goal? Picture the medication cart and weigh these possibilities. Option A, pegloticase. Option B, colchicine. Option C, probenecid. Option D, allopurinol. Time to lock in your answer. Here is the most likely prescription. Correct answer is option D, allopurinol. Let us unpack the reasoning so it truly sticks. Option D is correct because allopurinol, a xanthine oxidase inhibitor, blocks the enzymatic conversion of hypoxanthine and xanthine to uric acid, steadily lowering serum and urinary urate, shrinking tophi, and sharply reducing flare frequency. Since it tackles the underlying hyperuricemia instead of merely soothing inflammation, clients remain on it for life, even when symptom-free. Shifting to the alternatives, option A, pegloticase, is an intravenous recombinant uricase reserved for severe treatment-refractory gout with disabling tophi. Its high cost, infusion center requirements, and risk of dangerous infusion reactions keep it off the front line. Option B, colchicine interrupts neutrophil microtubule assembly to quell or prevent acute attacks, but does not influence urate production or excretion, so it cannot serve as chronic urate-lowering therapy. Option C, probenecid, boosts renal excretion of uric acid by blocking tubular reabsorption, yet it loses power when the estimated glomerular filtration rate dips below 30 milliliters per minute and is contraindicated in kidney stone disease, making xanthine oxidase inhibition the safer, more reliable path. Before we transition to the next challenge, tuck away these clinical pearls. Start allopurinol low at about 100 milligrams daily and titrate every 2 to 5 weeks toward a serum uric acid target below 6 milligrams per deciliter to avoid hypersensitivity. Pair the early months with low-dose colchicine or a non-steroidal anti-inflammatory drug to blunt mobilization flares. Reinforce solid hydration, weight management, limited alcohol, especially beer and spirits, and a low purine eating plan to amplify drug effectiveness. And keep a close eye on kidney function, liver enzymes, and complete blood count. Adjusting the dose in chronic kidney disease to prevent crystal nephropathy and systemic toxicity. Ready for another clinical curveball that could show up on the NCLEX? Here comes question 2. A 56-year-old client arrives in the emergency department with an exquisitely tender erythematous first metatarsalphalangeal joint. The uric acid level is 11 milligrams per deciliter, and the clinical team diagnoses an acute gout flare. During medication reconciliation, the nurse reviews the client's long-term prescriptions. Which home drug is the most likely pharmacologic trigger for this attack? Take a moment to weigh the choices. Option A, metoprolol. Option B, omeprazole. Option C, hydrochlorothiazide. Option D, paroxetine. Keeping in mind how each agent influences uric acid handling, the drug most likely responsible is option C, hydrochlorothiazide. Option C, hydrochlorothiazide, is the correct answer because this thiazide diuretic competes with uric acid for secretion in the renal proximal tubule, thereby raising serum urate concentrations, destabilizing monosodium urate deposits, and precipitating sudden gouty arthritis, especially when dehydration or a purine-rich meal adds extra stress. Option A, metoprolol, is not the trigger since this cardioselective beta-adrenergic blocker treats hypertension, heart failure, and rate control without altering uric acid production or excretion. Option B, omeprazole, is also not implicated because this proton pump inhibitor reduces gastric acid, yet leaves purine metabolism and renal urate transport untouched. Option D, paroxetine, does not fit either. Although this selective serotonin reuptake inhibitor can influence platelet activity or sodium balance, it does not elevate uric acid levels or provoke gout flares. Remember these clinical pearls as you move on. Thiazide and loop diuretics, low-dose aspirin, cyclosporin, tacrolimus, pyrazinamide, ethambutol, and niacin are classic medication triggers for gout. For hypertensive clients who suffer recurrent attacks, replacing hydrochlorothiazide with losartan or a calcium channel blocker offers a neutral or mildly uricosuric alternative. And a thorough medication history is vital because eliminating an avoidable drug can dramatically cut future flares and preserve joint health. Let's put your knowledge to the test with question 3. A 49-year-old client with a history of uric acid nephrolithiasis is starting allopurinol as long-term urate-lowering therapy. During discharge teaching, the client asks, "What is the most important thing I should remember while taking this medicine?" Which response by the nurse is most accurate? Each option tells a story. Let's break it down. Option A. A mild skin rash is common and you can keep taking the drug unless the rash worsens. Option B. Avoid citrus fruits because they reduce the effectiveness of allopurinol. Option C. Take the pill only when your joints start to ache. Option D. Be sure to drink at least 3 liters of water every day. The wisest advice in this situation is option D. Be sure to drink at least 3 liters of water every day. Here is why that answer stands tall. Option D is correct because allopurinol blocks xanthine oxidase, steadily reducing serum and urinary urate, and generous hydration of about 3 liters daily dilutes urinary uric acid and xanthine, helping to prevent crystal precipitation and kidney stone formation while tissue stores shift during early therapy. Turning to the other responses, option A is unsafe because even a seemingly mild rash may signal allopurinol hypersensitivity syndrome, a potentially fatal reaction that demands immediate discontinuation and urgent evaluation rather than continued use. Option B is inaccurate since citrus intake does not meaningfully alter allopurinol effectiveness. In fact, vitamin C may even promote a urine environment that is not harmful to urate excretion. Option C misses the mark because allopurinol is a preventive medication that must be taken consistently every day. Using it only when joints ache fails to provide acute relief and undermines long-term urate control. Before we move on, tuck away these pearls of practice. Start allopurinol low at about 100 milligrams daily and titrate slowly. Pair the first 3 to 6 months with low-dose colchicine or a non-steroidal anti-inflammatory drug to blunt mobilization flares. Teach clients to report any fever, rash, sore throat, or liver tenderness promptly, and monitor renal function, hepatic enzymes, and complete blood count to guide safe dosing and catch rare but serious adverse effects. Eyes on the screen, nursing stars. Here comes question 4. A 62-year-old woman with dual energy X-ray absorptiometry T-scores of -3.1 at the femoral neck is started on once-weekly oral alendronate for severe postmenopausal osteoporosis. Before administering the first dose, the nurse reviews the client's problem list for conditions that would make an oral bisphosphonate unsafe. Which documented diagnosis warrants contacting the prescriber to reconsider the medication route? Here are the options. Let's find the most correct one. Option A. Essential hypertension managed with amlodipine. Option B. Roux-en-Y gastric bypass performed 2 years ago. Option C. Primary hyperlipidemia treated with atorvastatin. Option D. Type 2 diabetes mellitus with a recent glycated hemoglobin of 6.8%. Time to decide the safest move. The diagnosis that should trigger a call to the prescriber is option B. Roux-en-Y gastric bypass performed 2 years ago. Option B is the correct choice because Roux-en-Y gastric bypass profoundly alters upper gastrointestinal anatomy and often leads to chronic bile reflux and marginal ulcers at the gastrojejunal anastomosis. Oral bisphosphonates, such as alendronate, can adhere to this vulnerable mucosa, causing severe ulceration, perforation, or strictures. So, current guidelines list this surgery as a contraindication to oral therapy and recommend an intravenous agent like zoledronic acid instead. Option A does not warrant a route change because essential hypertension controlled with a calcium channel blocker does not affect bisphosphonate pharmacokinetics or raise mucosal injury risk. Option C is not problematic since primary hyperlipidemia, even when treated with a statin, is unconnected to esophageal motility or mucosal vulnerability. Option D also fails to disqualify oral treatment because well-controlled type 2 diabetes mellitus does not interfere with esophageal transit or alendronate absorption. Keep in mind these pearls as you counsel clients. Oral bisphosphonates must be swallowed first thing in the morning with a full glass of plain water, followed by at least 30 minutes upright. Absolute contraindications include significant esophageal disorders, upper gastrointestinal anastomoses like Roux-en-Y bypass, inability to sit or stand upright, and untreated hypocalcemia. And if oral therapy is unsafe, yearly intravenous zoledronic acid or quarterly intravenous ibandronate can still deliver fracture risk reduction without gastrointestinal toxicity. Warming up those diagnostic muscles for an immune system deep dive. Here comes question 5. While reviewing the admission orders for a 44-year-old client, the nurse notices that the primary healthcare provider has initiated etanercept therapy. Based on its pharmacologic profile, the nurse understands that this biologic agent has been prescribed to manage which condition? Consider each possibility carefully. Option A, systemic lupus erythematosus. Option B, primary osteoporosis. Option C, rheumatoid arthritis. Option D, chronic hepatitis C infection. The condition that matches the mechanism of etanercept is option C, rheumatoid arthritis. Correct answer is option C, rheumatoid arthritis. As etanercept is designed for rheumatoid arthritis because it is a soluble tumor, necrosis factor receptor fusion protein that binds to and neutralizes circulating tumor necrosis factor alpha, the pro-inflammatory cytokine driving synovial inflammation and progressive joint destruction. Regular subcutaneous injections reduce pain, slow radiographic damage, and improve physical function in clients whose disease has not responded adequately to conventional disease-modifying anti-rheumatic drugs. In contrast, option A, systemic lupus erythematosus, is not routinely treated with tumor necrosis factor blockade. In fact, etanercept can provoke a drug-induced lupus-like syndrome, so using it may worsen rather than relieve the disease. Option B, primary osteoporosis, results from an imbalance between osteoclastic bone resorption and osteoblastic bone formation. First-line therapy relies on oral or intravenous bisphosphonates or anabolic agents such as teriparatide, whereas inhibiting tumor necrosis factor does not increase bone mineral density. Option D, chronic hepatitis C infection, is managed with direct-acting antiviral combinations that inhibit viral protease, viral polymerase, or non-structural protein 5A replication complexes. Etanercept modulates host immune signaling and carries a risk of viral reactivation, rendering it useless and potentially harmful for treating hepatitis C. Before we move on to the next NCLEX challenge, keep these practice points top of mind. Obtain baseline tuberculosis screening with either an interferon gamma release assay or a purified protein derivative skin test, and check hepatitis B surface antigen and core antibody, because latent infection can reactivate under tumor necrosis factor inhibition. Teach clients how to rotate subcutaneous injection sites in the interior thigh or abdomen, and to report any persistent redness or pain, because local injection site reactions are the most common adverse effect. Schedule all required live vaccines such as measles, mumps, rubella, or varicella before the first dose because they become contraindicated once treatment begins. And instruct clients to seek immediate medical attention for fever, productive cough, unexplained weight loss, or night sweats, which could signal an opportunistic infection during etanercept therapy. Switching gears to a vital bone health scenario, here comes question 6. Question 6. A 71-year-old woman with a dual energy X-ray absorptiometry T-score of -3.2 at the femoral neck is beginning once-weekly oral alendronate for severe osteoporosis. During teaching, she asks, "I know this pill is supposed to protect my bones, but what does it actually do inside my body?" How should the nurse answer? Now, let's review the possible answers. Option A, it enhances osteoclastic breakdown of old bone. Option B, it suppresses bone resorption and slows mineral loss. Option C, it thickens synovial fluid to cushion the joints. Option D, it raises parathyroid hormone levels to mobilize calcium. The explanation that truly reflects alendronate's effect is option B. It suppresses bone resorption and slows mineral loss. Here is the reasoning in full. Option B is accurate because alendronate is a nitrogen-containing bisphosphonate that binds to hydroxyapatite in bone and disrupts the mevalonate pathway inside osteoclasts, selectively inhibiting their resorptive activity, increasing bone mineral density, and demonstrably reducing vertebral, hip, and wrist fracture risk. Turning to the distractors, option A is incorrect, since enhancing osteoclastic breakdown would accelerate demineralization, the opposite of alendronate's therapeutic goal. Option C is off base because synovial fluid viscosity pertains to arthritic joint disorders, whereas alendronate exerts no influence on joint lubrication. Option D does not fit because pharmacologic parathyroid hormone, analogs such as teriparatide, build bone by intermittent osteoblastic stimulation. Alendronate actually traps calcium in bone and, if dietary intake is low, may even transiently lower serum calcium. Keep in mind as you counsel clients that alendronate must be taken first thing in the morning with a full glass of plain water, followed by at least 30 minutes upright and nothing else by mouth to minimize esophageal irritation. Absolute contraindications include severe esophageal disease, recent Roux-en-Y gastric bypass, achalasia, and inability to remain upright, in which case intravenous zoledronic acid offers a safer route. Ensure daily calcium of 1,000 to 1,200 milligrams and vitamin D of 800 to 1,000 international units to prevent hypocalcemia, and reassess fracture risk after 3 to 5 years, because low-risk clients may qualify for a drug holiday to reduce the rare complications of atypical femoral fracture and osteonecrosis of the jaw. Stay tuned. A fresh NCLEX challenge is coming up next to keep your clinical reasoning razor sharp. Quick pause before we jump into the question. Are you NCLEX ready? If not, the complete NCLEX Review online course gives you everything you need: 100 hours of animations, 500 hours of recorded lectures, 5,000 top-rated questions, 500 NGN case-based study, and 15 CAT-style mock exams. It also comes with a detailed NCLEX ebook. All yours for an entire year. Limited time offer. Get 70% off today. Thousands have passed, now it's your turn. Visit our website using the link below. Gear up for another critical teaching moment. Here is question 7. A 64-year-old woman recently diagnosed with osteoporosis receives a prescription for an oral bisphosphonate. During the teaching session, which specific instruction should the nurse stress to promote both efficacy and gastrointestinal safety? Now, as you picture this scenario, consider the options ahead. Option A, swallow the tablet after breakfast to minimize stomach upset. Option B, take the dose at bedtime and immediately lie flat to speed delivery to the stomach. Option C, on an empty stomach first thing in the morning, swallow the tablet with a full glass of water and remain upright for at least 30 minutes. Option D, dissolve the tablet in water if swallowing pills is difficult. Ready to settle on the best approach? The answer that safeguards both absorption and the esophagus is option C. On an empty stomach first thing in the morning, swallow the tablet with a full glass of water and remain upright for at least 30 minutes. Let us unpack why this instruction is non-negotiable. Oral bisphosphonates cling tightly to the esophageal lining if they are not flushed swiftly downward by a large volume of plain water and the pull of gravity. Taking the tablet first thing on an empty stomach with 240 milliliters of water and staying upright for at least 30 minutes maximizes drug uptake in the proximal small bowel and prevents corrosive injury such as esophagitis or ulcer formation. By contrast, swallowing the tablet after a meal, as in option A, drastically reduces absorption because dietary calcium, magnesium, and other cations bind to bisphosphonates in the gastrointestinal tract, converting them into insoluble complexes that never reach the bone. Likewise, taking the dose at bedtime and lying flat, as in option B, prolongs mucosal contact, sharply raising the risk of esophageal irritation, erosion, and eventual stricture, an outcome we strive to avoid. Finally, dissolving or crushing the tablet, as in option D, is contraindicated. Altering the solid dosage form disrupts its coating and concentrates the active drug on the throat and esophagus, heightening caustic effects without improving bioavailability. By emphasizing the empty stomach, full glass of water, and upright for 30 minutes approach, the nurse ensures the bisphosphonate travels quickly to the absorption site and spares the esophagus, which is exactly how we optimize treatment outcomes for osteoporosis. Sliding smoothly into our next osteoporosis conversation, here is question 8. A 72-year-old woman with a history of fragility hip fracture is beginning denosumab therapy for severe osteoporosis. When the client asks what the injection actually does for her bones, how should the nurse respond? Shift your attention as I present the choices. Option A. It blocks rank L, stopping osteoclast activity and thereby reducing bone resorption. Option B. It speeds the maturation of osteoblasts so you grow new bone faster. Option C. It makes your parathyroid gland release more hormone to help you absorb calcium. Option D. It acts like estrogen in the spine to cut vertebral fracture risk. Take a moment to connect mechanism with outcome, because the statement that correctly describes denosumab's action is option A. It blocks rank L, stopping osteoclast activity and thereby reducing bone resorption. Now let us unpack why this response is spot on and why the other explanations miss the mark. Denosumab is a fully human monoclonal antibody that binds receptor activator of nuclear factor, kappa B ligand, or rank L, the essential cytokine osteoblasts and stromal cells produce to stimulate osteoclast precursors to differentiate, activate, and survive. By sequestering rank L before it can engage its receptor, denosumab halts formation of new osteoclasts and triggers apoptosis in existing ones, which leads to a rapid drop in bone resorption markers, such as serum C-terminal telepeptide, within days. Over months, bone mineral density climbs in both cortical and trabecular compartments, significantly lowering vertebral, non-vertebral, and hip fracture rates in high-risk clients, because this powerful anti-resorptive effect can also reduce serum calcium, especially in clients with chronic kidney disease or vitamin D deficiency. It is critical to ensure adequate intake of at least 1,000 milligrams of elemental calcium and 800 to 1,000 international units of vitamin D daily before and during therapy. Suddenly stopping denosumab can provoke a rebound increase in bone turnover, measured by a surge in N-terminal telepeptide levels, and lead to multiple vertebral fractures within months. Transitioning to a bisphosphonate such as alendronate or zoledronic acid mitigates this risk. Rare but serious skin and soft tissue infections, including cellulitis, have been reported, so advising clients to report fever, erythema, or non-healing wounds promptly is key to catching complications early. By contrast, option B describes the mechanism of anabolic agents like teriparatide or abaloparatide, which act as recombinant human parathyroid hormone analogs to transiently stimulate osteoblastic activity and bone formation. These agents increase bone turnover markers initially and are reserved for clients with very high fracture risk or those intolerant of anti-resorptives, not denosumab users. Option C incorrectly suggests denosumab increases parathyroid hormone release. In reality, denosumab can lower serum calcium by blocking bone resorption, so clinicians correct any hypocalcemia first, rather than relying on secondary hyperparathyroidism to boost absorption. Finally, option D confuses denosumab with selective estrogen receptor modulators, such as raloxifene or even hormone replacement therapy, which bind estrogen receptors in bone to decrease resorption and reduce vertebral fracture risk. Denosumab has no estrogenic action and does not address menopausal vasomotor symptoms or breast cancer considerations. By explaining that denosumab specifically neutralizes receptor activator of nuclear factor kappa B ligand, which is also called rank L, to shut down osteoclasts, reminding clients about calcium and vitamin D supplementation, warning about rebound effects if therapy is stopped abruptly, and alerting them to watch for signs of infection, the nurse ensures that both efficacy and safety are maximized in the journey to stronger bones. Focus in. This could be a potential exam question. Here comes question 9. A 59-year-old man with chronic glucocorticoid use is scheduled to start daily teriparatide for steroid-induced osteoporosis. Which pre-existing condition should cause the nurse to question this prescription? Now, let us line up the clinical details to guide your choice. Option A, essential hypertension managed with hydrochlorothiazide. Option B, intermittent gastroesophageal reflux disease. Option C, well-controlled type 2 diabetes mellitus. Option D, Paget disease of bone diagnosed 5 years ago. Pause and let each condition roll through your mind. The correct answer is option D, because the one that truly disqualifies teriparatide is option D, Paget disease of bone diagnosed 5 years ago. Here is why, with extra depth to cement the concept. Teriparatide is a recombinant human parathyroid hormone fragment, consisting of the first 34 amino acids. When administered once daily, it stimulates osteoblast differentiation and activity by transiently increasing cyclic adenosine monophosphate in osteoprogenitor cells, thereby promoting new bone formation and improving trabecular microarchitecture. Because of these anabolic effects, teriparatide is especially useful for severe osteoporosis or glucocorticoid-induced bone loss. Option A, essential hypertension managed with hydrochlorothiazide, does not contraindicate teriparatide because thiazide diuretics only mildly increase serum calcium by reducing renal calcium excretion, an effect that is predictable and monitored through periodic calcium checks. Option B, intermittent gastroesophageal reflux disease, is not a barrier to teriparatide treatment because the medication is administered by subcutaneous injection, completely bypassing the gastrointestinal tract, unlike oral bisphosphonates, which can irritate the esophagus. Option C, well-controlled type 2 diabetes mellitus, does not increase the risk of osteosarcoma, nor does it interfere with teriparatide's mechanism of action. Diabetic clients simply require routine monitoring of blood glucose and calcium levels. However, option D, Paget disease of bone diagnosed 5 years ago, is the only pre-existing condition that should prompt the nurse to question a teriparatide prescription. Because Paget disease is characterized by areas of accelerated and disorganized bone remodeling, driven by abnormal osteoclast activity, followed by incoherent osteoblastic repair. Animal studies have demonstrated that prolonged parathyroid hormone stimulation, in the setting of disordered bone turnover, can lead to osteosarcoma. And although such cases are exceedingly rare in humans, the theoretical risk is unacceptable. In this situation, the nurse should anticipate an alternative therapy, such as an anti-resorptive agent, often a bisphosphonate or denosumab, to rebalance bone turnover without further stimulating osteoclastic activity. Launching into our next critical lab review, here is question 10. A client with long-standing rheumatoid arthritis receives methotrexate 25 mg weekly. Which laboratory result should prompt the nurse to hold the next dose and notify the prescriber? Consider your choices carefully. Option A, alanine aminotransferase 45 units per liter. Option B, absolute neutrophil count 800 microliters. Option C, serum creatinine 1.0 milligrams per deciliter. Option D, mean corpuscular volume 96 femtoliters. The result that mandates immediate action is option B, absolute neutrophil count 800 microliters. Methotrexate exerts its effect by inhibiting dihydrofolate reductase, which reduces folate availability and suppresses rapidly dividing cells, including bone marrow precursors. An absolute neutrophil count below 1,000 cells per microliter signifies moderate to severe neutropenia, placing the client at high risk for life-threatening infections. Continuing methotrexate in this context could allow opportunistic bacteria or fungi to overwhelm the compromised immune system. The prescriber may need to order leucovorin rescue, reduce the methotrexate dose, or refer to a hematologist for further evaluation. In contrast, option A, an alanine aminotransferase of 45 units per liter, represents only a mild elevation, less than twice the upper limit of normal, and is often reversible with lifestyle adjustments and close monitoring. Current guidelines recommend ongoing surveillance of liver enzymes rather than immediate cessation at this level unless a trend shows further elevation. Option C, a serum creatinine of 1.0 milligrams per deciliter, indicates preserved renal function, as dose modifications for methotrexate are generally required only when the estimated glomerular filtration rate falls below 60 milliliters per minute. Nevertheless, consistent monitoring of renal function remains essential especially in older adults or clients taking other nephrotoxic medications. Option D, a mean corpuscular volume of 96 femtoliters, reflects mild macrocytosis without concurrent cytopenias. This laboratory finding is a predictable consequence of folate antagonism and is typically mitigated by daily folic acid supplementation. Holding therapy solely on the basis of elevated mean corpuscular volume would deprive the client of a cornerstone disease-modifying agent without clear benefit. By identifying neutropenia promptly, the nurse safeguards against severe infection and helps the prescriber tailor the methotrexate regimen to balance efficacy with safety. Let's test your nursing instincts with question number 11. A 45-year-old office worker is given cyclobenzaprine, 10 milligrams 3 times daily for acute lumbar spasm. What is the most important instruction for safe medication use? Now let us review the options. Option A, take the tablet on an empty stomach to speed absorption. Option B, expect this drug to reduce local inflammation in your back muscles. Option C, do not drive or operate machinery until you know how the medication affects you. Option D, report dark-colored urine, which could signal liver damage. The critical safety instruction is option C, do not drive or operate machinery until you know how the medication affects you. Cyclobenzaprine shares a tricyclic antidepressant core that produces potent antihistaminic and anticholinergic sedation. As a result, reaction times slow and attention can be impaired, especially during the first 48 to 72 hours. By warning clients about possible drowsiness and advising them to avoid hazardous tasks such as driving or operating heavy machinery until they understand how it affects them, the nurse prevents motor vehicle or workplace accidents and reduces liability. In contrast, taking the tablet on an empty stomach, as suggested in option A, is unnecessary because cyclobenzaprine's absorption is not significantly altered by food. In fact, ingesting it with meals can alleviate dyspepsia for some clients. Believing that the drug reduces local inflammation, as in option B, is a misconception. Cyclobenzaprine acts centrally at the brainstem level to dampen somatic motor activity and does not inhibit prostaglandin synthesis or cytokine release in peripheral tissues. Finally, reporting dark-colored urine, as described in option D, is unlikely to be helpful because severe cyclobenzaprine-related hepatotoxicity is very rare, and routine liver enzyme monitoring is not recommended. Emphasizing sedation safety ensures clients remain functional and injury-free while gaining relief from their muscle spasm. Buckle up for another drug safety check. Here comes question 12. A 70-year-old woman with stage 3 chronic kidney disease is admitted for pneumonia and started on clarithromycin. She also takes colchicine 0.6 milligram daily for gout prophylaxis. What change should the nurse anticipate? Now shift your focus as the options appear. Option A, increase colchicine to prevent a flare during illness. Option B, add probenecid while continuing colchicine at the same dose. Option C, switch colchicine to naproxen on an equal milligram basis. Option D, discontinue colchicine immediately to avoid serious toxicity. Pause and consider how clarithromycin affects drug metabolism, because the safest and most evidence-based move is option D, discontinue colchicine immediately to avoid serious toxicity. Let us unpack why this decision stands out and why the other choices miss the mark. Clarithromycin is a potent inhibitor of cytochrome P4A4 and permeability glycoprotein, both of which are critical for colchicine elimination. In a patient whose glomerular filtration rate is already reduced by stage 3 renal impairment, colchicine can accumulate rapidly, leading to potentially fatal consequences such as rhabdomyolysis, severe gastrointestinal distress, pancytopenia, bone marrow suppression, and multi-organ failure. By discontinuing colchicine as soon as clarithromycin is prescribed, the nurse prevents the drug from reaching toxic levels. In contrast, increasing colchicine under these circumstances, as in option A, would exponentially raise the risk of life-threatening adverse effects because it compounds impaired elimination rather than preventing gout. Adding probenecid, as in option B, directs treatment toward urate excretion, but does nothing to enhance colchicine clearance. Moreover, probenecid is ineffective when the estimated glomerular filtration rate falls below 50 milliliters per minute. Switching colchicine to naproxen on a unit-to-unit basis, as in option C, fails to consider differences in mechanism of action and relative potency. Introducing a non-steroidal anti-inflammatory drug alone may also worsen renal function in a patient already classified with stage 3 chronic kidney disease. By discontinuing colchicine and monitoring for gout flares, the nurse paves the way for an alternative prophylactic approach, such as low-dose corticosteroids or a temporary non-steroidal anti-inflammatory regimen, until clarithromycin is complete and renal function stabilizes. Hold up! Are you feeling confident about the NCLEX? If not, you'll want to check out the complete NCLEX Review online course. It's packed with 100 hours of animated videos, 500 hours of deep content, 5,000 practice questions, 500 NGN-style case study, and 15 full mock exams. There's also a full NCLEX ebook included, with a 1-year access window. And right now, it's available for 70% off, but only for a short time. Click the link in the description and join the thousands of students who've already passed. Let us pivot to medication allergies and safety for a moment. Time to apply your critical thinking with question 13. A client with knee osteoarthritis receives a prescription for celecoxib. Which allergy history should prompt the nurse to question this order? Now shift your attention as I lay out the possible histories. Option A, springtime pollen makes me sneeze. Option B, codeine always upsets my stomach. Option C, sulfonamide. Antibiotics gave me hives. Option D, I flush when I drink red wine. Take a moment to link each allergy to celecoxib's structure before settling on the correct choice. Option C, sulfonamide antibiotics gave me hives. Here's the detailed reasoning for that selection and why the others do not raise the same red flag. Option C is correct because celecoxib contains a sulfonamide side chain. And although cross-reactivity between sulfonamide antibiotics and sulfonamide non-steroidal anti-inflammatory drugs is rare, the risk of an immediate hypersensitivity reaction, such as urticaria, anaphylaxis, or Stevens-Johnson syndrome, cannot be dismissed in someone who has reacted to sulfonamide antibiotics before. In contrast, Option A describes seasonal allergic rhinitis to pollen, which is mediated by immunoglobulin E and has nothing to do with sulfonamide moieties in celecoxib's chemical structure. So hay fever does not predict nonsteroidal anti-inflammatory drug hypersensitivity. Option B indicates codeine-induced nausea, a side effect resulting from central emetic center stimulation, rather than a true hypersensitivity reaction mediated by immunoglobulin E or T lymphocytes. And it does not imply cross-reactivity with celecoxib. Option D refers to alcohol flush syndrome, which arises from genetic variants in histamine metabolism and alcohol dehydrogenase, completely unrelated to celecoxib's mechanism of cyclooxygenase R2 inhibition, or its sulfonamide component. By identifying that a sulfonamide antibiotic allergy could translate into a serious reaction to celecoxib, the nurse ensures this prescription is reviewed and an alternative analgesic, such as a non-acetylated salicylate, acetaminophen, or tramadol, is considered instead, all while documenting the rationale to safeguard the client from inadvertent re-challenge. Sliding right into our next teaching moment with question 14. A 50-year-old woman with painful vertebral compression fractures is prescribed intranasal calcitonin. Which instruction should the nurse emphasize? Now steady your focus as we review the possible directives. Option A, lie flat for 30 minutes after each dose. Option B, alternate nostrils daily and report persistent irritation. Option C, use a decongestant spray immediately beforehand. Option D, take the spray with a full glass of milk. Digest each instruction carefully, because the one that truly protects the nasal mucosa and maximizes absorption is Option B, alternate nostrils daily and report persistent irritation. Here is why that recommendation matters most, explained step by step. Intranasal calcitonin delivers salmon-derived peptide directly onto the nasal mucosa, which can trigger local side effects such as rhinitis, pinpoint bleeding or epistaxis, and even ulceration if one nostril bears the full brunt every day. By rotating nostrils daily, you distribute the drug's local effect and give each nasal passage time to recover, while prompt reporting of any persistent burning or crusting alerts the healthcare team to adjust dosage frequency, add saline rinses, or switch to an alternative anti-resorptive therapy before more severe mucosal damage occurs. In contrast, lying flat for 30 minutes after each dose, as suggested in Option A, does not enhance nasal absorption because gravity does not affect the drug once it is deposited and adhered to the mucosa. In fact, lying flat may worsen postnasal drip and throat irritation. Relying on a decongestant spray immediately beforehand, as in option C, risks drying and inflaming the nasal lining further, potentially compounding calcitonin irritation. Decongestants should be used only under prescriber guidance for specific short-term congestion, not as a routine premedication. Finally, taking the spray with a full glass of milk, as described in option D, confuses the client because intranasal calcitonin bypasses the gastrointestinal tract entirely, so milk has no impact on its efficacy and may even distract from the correct administration technique. By emphasizing daily nostril rotation and swift reporting of any discomfort, the nurse ensures both effective delivery and safe long-term use of intranasal calcitonin for pain relief and modest anti-resorptive benefit in acute vertebral fractures. Leaning into your pharmacology toolkit, here is question 15. A construction worker with chronic back pain takes ibuprofen 800 milligrams 3 times daily. The prescriber adds misoprostol. Which statement suggests the new drug is achieving its intended purpose? Now, let us scan the possibilities. Option A, my back finally feels better. Option B, my ankles are not swelling now. Option C, my stomach no longer burns after I take ibuprofen. Option D, I am not as drowsy at work anymore. Take a moment to connect misoprostol's mechanism with each outcome, because the clue that confirms protection of the gastric lining is option C, my stomach no longer burns after I take ibuprofen. Let us unpack why this choice hits the mark and why the others miss the point. Misoprostol is a prostaglandin E, one analog designed to replace the gastroprotective prostaglandins that non-steroidal anti-inflammatory drugs like ibuprofen suppress. By stimulating mucus and bicarbonate secretion in the stomach and enhancing mucosal blood flow, it fortifies the gastric barrier and prevents ulcer formation. So, when a client reports freedom from epigastric burning, that signals misoprostol is doing its job. By contrast, pain relief in the back, as mentioned in option A, stems entirely from ibuprofen's cyclooxygenase inhibition and has nothing to do with misoprostol's action, which does not block pain signals. Reducing ankle swelling, as in option B, relates to non-steroidal anti-inflammatory drug-induced renal sodium retention and fluid accumulation. Misoprostol does not mitigate renal effects or edema, so any change in swelling would not be attributed to this prostaglandin analog. Finally, feeling less drowsy, as described in option D, has no link to misoprostol. This medication is more commonly associated with diarrhea and abdominal cramping rather than sedation, so any improvement in alertness likely reflects adaptation to ibuprofen or other external factors, not misoprostol use. By teaching clients to watch for relief from heartburn or indigestion while on misoprostol, the nurse confirms that the gastric mucosa is protected and that the combination therapy balances effective pain control with minimized gastrointestinal risk. And that concludes today's look at pharmacology of musculoskeletal, another powerful boost for your NCLEX prep. Stay tuned, because we return very soon with fresh, essential content designed to sharpen your skills and knowledge every single day. Make sure to follow us and keep watching, as our daily videos deliver the critical topics and practice questions you need to pass the NCLEX with confidence.